We are now coming to the next session, which is the open forum. This will be chaired by Prof. Amit Gupta and the two moderators, Ben and myself. I would like to also invite the conference speakers, the faculty and the reactor to this forum to discuss some of the questions that was posted in the Q&A chat.
Thank you. Thank you, Dr. Jerry. Thanks a lot. And just to roll out the wonderful open forum where we discuss most of the queries raised by the participants and also to discuss some other queries amongst the panelists. We had a wonderful session on critically injured patients in ICU, highlighting, I think, four of the most important topics. One, bleeding. Second, pain management. Third, nutrition. And fourth, antibiotics. All of them conflicting, all of them having some of the other institutional policies which are not congruent, which are not defined by guidelines. And most of the speakers sort of stressed on the fact that guidelines are there, but the evidence is conflicting in most of these four important issues of critically injured patients. So we'll begin with the first lecture and the queries therein. And I would request our moderator, Dr. Benedict, to raise any questions which were raised by the participants and ask. Probably we don't have a fifth speaker here. Probably Dr. Resurrection would bail us out with the questions, or any other faculty member or reactors who would like to take up those questions. Dr. Benedict.
Yes, thank you. Thank you for that. Anyway, there's a question and answer here that is quite comprehensive, and I would like to choose this one. And there's a question coming from Mr. Emmanuel Joshua Garcia, and there have been recent papers on the utility of plasma products on shock due to its effect on the endothelial glycocalyx. Do you have any experience regarding the use of plasma products such as fresh frozen plasma over crystalloids in these cases? And thank you in advance.
Dr. Resurrection, would you like to comment upon the use of fresh frozen plasma or plasma products early in the resuscitation, maybe in the ED? Any experience regarding that?
Blood products nowadays, but the problem is also always availability. We do try to get to our close ratio transfusions of FFP, platelet, and RBCs, but it's more of a wish list. What we have in the Philippines is a very dire lack of blood. We actually transfuse it as they arrive. It's not like we have a cooler of 4 of each or 6 of each of these products. So with regard to the glycocalyx, I think the more important problem is over-resuscitating with fluids. I think with the newer ATLS guidelines, the recommendation is to limit resuscitation to only 1 liter. Hopefully that the patient improves, and if that doesn't work, then probably start right away, even in your emergency departments, with blood transfusions. There is already a paradigm shift with regard to resuscitation, and it's that we're going back to blood, whole blood to replace blood that's lost in trauma. Unlike before, in the perhaps in the late 1990s, it was more of fluids, giving fluids, hopefully, to address the problem of ischemia or hypoperfusion by allowing whatever RBCs are left to circulate in these patients. Unfortunately, we have a lot more problems with regard to fluid leaving the intravascular compartment, and it obviously does not carry any oxygen. So we're going back again to the basics, and I think blood, in effect, will be becoming more important, and perhaps what we should focus on, perhaps in our countries, is improving blood banking and availability of walking blood banks in civilian practice, pretty much what they have in military conflict areas. Thank you.
For the general public, how do you give enteral nutrition in trauma patient? Do you give the total calculated caloric requirement or just a percentage and progressive increase in amount. How about parental nutrition? How about in burn patients? This question is actually directed to Dr. Lim Jiayan.
So I think in terms for trauma patients, I would choose to give feed enterally, and I wouldn't feed 100% at the first point in time, as what has been said earlier. So I would start slightly lower, 70%, and progressively increase it, because there is no need to rush to give 100% of nutrition immediately at the point in time when the patient is at ICU. Subsequently, if the feeding is tolerated, then you can slowly escalate it. Parenteral nutrition, I would say the role in trauma patients is probably quite not so great, because most trauma patients actually don't have bowel injury and they can tolerate enteral nutrition. I would give about 70% and then slowly progressively increase up to 100%.
I have a query for Dr. Jia regarding nutrition. There's been a lot of talk about early trophic feeds, especially in shock patients, wherein it was a relative contraindication at certain point of time. There are a lot of researches going on now on early trophic feeds. What are your views on early trophic feeds, in especially those patients who are in the ICU, getting resuscitated, still not fully resuscitated, in shock? What are your views on that?
So I would think that in patients who are not resuscitated sufficiently, sometimes giving them trophic feeds can cause more problems, because when you give feeds, you're trying to increase perfusion to the bowel as well. And sometimes that can actually result in bowel ischemia if you try to feed them if they are not poorly resuscitated. So I would think I would still wait for more definitive evidence to show that there is some benefit in giving trophic feeds for patients who are under resuscitated. But for now, I would still hold off feeding in patients who are not well resuscitated yet.
Right. Also, one question for the reactor of Dr. Jia's talk. I think Dr. Fernando is here. Dr. Fernando, just a question on the role of anabolic steroids, especially in chronic patients, sepsis, or maybe those patients who've gone into catabolic state. What are you using that? Anabolic steroids like decadurabolin. Some of us tend to use it in the ICUs.
Personally, I haven't used anabolic steroids very much. I've only seen it used once or twice in patients who are in the chronic and recovery phase. Not so much in trauma, but who had more of a traumatic brain injury in older patients. I would say that there is the patient who I saw who got anabolic steroids actually did get better. So he had difficulty weaning off the ventilator. So there probably will be some benefit in certain populations, but I wouldn't rush to give it to all patients. And a lot of times, I think the priority will still be to give enough sufficient nutrition in terms of protein as well as calories, and then to get them moving, get them going under rehabilitation to improve the muscle strength as well.
Right, thank you. I'd request my moderator friend, Dr. Jerry Gu, to go ahead and ask any questions from the second lecture, which was on pain management, early pain management. We saw Dr. Louis very elusively detailing that the pain should be the fifth vital sign, and also reversing the ladder of analgesia. Dr. Jerry, any questions?
Yes, for the topic on analgesia by Louis Ng, there is a question on what is the most effective pain treatment in early phase of trauma, and how does the hospital can ideally incorporate the pain management, because there are several parts like anesthetist, surgeon, or even acute pain services.
I think the scenario is definitely complex in any trauma service, trauma scenarios. I think the main aim of any trauma service in managing a patient holistically is to have a good trauma service where there is feedback from both the anesthetist, the ED physician, the trauma physician, as well as the ICU physician. If you talk about the most effective and the most straightforward way to administer analgesia at the start, is obviously intravenously, be it morphine or ketamine or anything that you guys have on hand. As for the subsequent management, obvious communication within different teams is of paramount importance. I think I did highlight that somebody asked about how we integrate pain management into our service. Trauma resuscitation service is very closely led by anesthetists. And since anesthetists are also the pain physicians, we have a head start in managing pain. And in our institution, our pain physicians are actually pretty much, our anesthetists are pretty much very regional anesthesia oriented. Example, me, I may be an intensivist, I may be a resuscitator, I may be a trauma physician, I may love ECMO, etc. I still put in nerve blocks. So no big issues in my ICU. You come in here, you have a hip trauma, you may be bleeding, you're in pain, I can still put in a powerful or ESP catheter for you. If you can turn around safely, that's the main thing. So getting a service that has integrated services linked together, I think that is probably the easiest way out. But if yeah, that's the main thing. I think getting integrated services on board.
Do you think currently there's a lack of awareness of analgesia, especially in a semi-conscious or very critically unstable patient in A&E? And how can we improve that if there is a issue?
So it really depends on who is managing it. I think with a patient that's semi-conscious, that's worried about GCS, there's always the worry and the concern about not giving analgesia or sedation for this patient. The scenarios are usually complicated when patients are borderline GCS 10 to 8. Should I intubate? Should I not intubate? Not quite here, not quite there. Sometimes GCS 14, sometimes 10, sometimes 8, but there is definitely trauma. Should I then give sedation? Should I not? That's actually the point where you get the most conflict. Those less than GCS 8, quite straightforward. Just tube and then be done with it. Those GCS 15, they're screaming away, shouting at us. You probably have to give something to shut them out anyway. So those that's in between. So are we lacking in that? So I believe there is a certain restraint, especially when the person running resus is a bit more junior. So educating them, exposing them to different forms of analgesia on the spot, telling them what is the correct way to secure the airway and then manage the rest of the stuff rather than worry about GCS may be the way forward. But of course, there's no one-way fit all kind of thing. Some patients we may really just need watching without intubating them, but yet others may benefit more on the spot. It's a very dynamic situation, but at the same point in time, it's hard to handle. So it is going to be difficult on the point of time. You will need someone that's senior that can guide. Yet at the same point in time, if you're going to intubate, you need to be very watchful, very cautious, have very set target points on what you want to monitor, rather than be fearful of committing to one way or the other. I mean, main aim, probably the way forward to all trainees and all physicians is whichever way you choose, have a backup plan, have something to monitor, have something to fall back on, and then go from there.
Okay, Louis, your lecture is wonderful. I want to ask you a little thing about the huddle, because we got a bunch of trauma patients with a head injury or alcoholic, and I think my personal experience, the huddle is very safe thing and can cooperate with your pain medicine. How do you think about that?
I think thank you so much for compliments, and I think the huddle is a wonderful idea. Unfortunately, even in no matter how we see it, sometimes huddle is not done even in the best intentions. Huddle is always a good idea, but if the huddle is not done properly, in my hospital we tried huddles for many things. The cooperation for huddles just sometimes don't come up by itself. I mean, getting a good huddle, getting information across, getting feedback, I think that's the best thing forward. But until the time when we can get a huddle where people actually listen to each other, which is actually the main aim of the huddle. But the problem is getting people to listen to each other during the huddle itself. Sometimes a lot harder than we think it is. So I do preach for huddles before major surgeries, before it's resus, and I also preach for huddles post resus, so that we can learn about what has happened so far. What do we think we could have done better? But yet at the same point of time, it is technically difficult to execute, especially during a resus, because time is of the issue. There are many people who will not listen, may not be listening. And then, of course, the other thing that we always run into is the problem getting each other together post-resuscitation for harder. it's almost impossible to gather everyone back once everyone's walked out of theater or the ICU. Everyone is busy. So I think harder is an extremely good idea, but I'm still struggling to, or at least my institution and me is still struggling on how to execute it in a way that it benefits everyone. I'm not sure how do you do that? I mean, how was the experience? If you guys have been doing that, we would like to learn how to do it harder properly because we are still struggling.
Yes, Louis, we also have the same issue. While we like to have a briefing and debriefing after every trauma resuscitation, having the same team members together is extremely difficult. Usually because they have something else to do, like rushing the patient to operating theater, etc., etc. One more question for you, Louis, by Napoleon de Guzman. What do you think of use of morphine liberally for procedure like sternotomy and thoracotomy in maybe in an institution that don't practice much regional anesthesia? What would be the downside of using too much opioid, and how do you balance that?
I think for sternotomies and thoracotomies, they are extremely painful from what I know about from cardiac anesthesia and even from trauma. They are extremely tender, they are extremely painful. Poorly managed analgesia with cardio sternotomy, midline sternotomy, or thoracotomy can lead to a lot of issues. Ventilator desynchrony, what's that thing called? Even tamponades kind of thing because of acute straining on the left ventricle, especially post-cardiac surgery. Those are extremely common issues we face with patients that's not managed properly for analgesia post-cardiac surgeries. So yes, I think liberal opioids is the way to go, especially in the population that are extremely sensitive to pain. And these patients has got a surgery that warrants a very good analgesia. So I would say that for them, I think no issues. Just write them hard, make sure they're comfortable, then win them safely. If that's the main issue, we don't always provide regional anesthesia for patients that goes for inline sternotomy because that is generally hard to do. As for thoracotomies, I think the surgeons generally do place a lot of pleural catheters. We don't need to have a good regional anesthesia service. We just need to have a good surgeon that's trained in putting the catheters in. I think that will do wonder. Even if you don't have to put the catheter in, a single shot injection usually lasts for about good 4 to 6 hours. And that's, of course, I'm not the one performing surgery. It probably will be easier than asking the anesthetist to turn the patient, put in a catheter post-operatively, giving it intra through a scope, direct vision. I think that will probably be good for thoracotomy.
Thank you, Dr. Louis. In the interest of time, Dr. Jerry, a couple of more very pressing questions if you have for any of the talks. Yes,
Lowell is not here with us, but I'll open this question about antibiotic to the rest of the experts. One is the use of procalcitonin in detecting sepsis or infection. Is that something that your institution do? And does that help to guide the appropriate antibiotics? Secondly, on antibiotic is, what do you think of the delayed initiation of antibiotic in an ICU-related infection versus early initiation of antibiotics?
So procalcitonin, I think we usually use it to look for, it's an infective marker, so we use it to look at bacterial infections. I think in the trauma population, the procalcitonin may actually be raised, so may not be as accurate. But I would still use it to look at it as a trend to see, to guide my treatment. So whether it's a uprising or a downtrending trend, and not just look at it as a specific single number.
Yeah, I think absolutely right. It's the trends in the ICU, especially procal trends, which are important. Any comment on that, Dr. Louis, from your side?
Hi, I think I agree with Jia Yan. I mean, procalcitonin CRP is something that we use frequently in our ICU too. I think the most important thing in guiding antibiotic treatment is that there must be a strong suspicion or indication of infection that's present that the clinical teams suspect on. inflammatory markers are never the best way to go forward. Looking at the patient response, suspecting which system it is that's infected, looking for derangements of that system will probably tell us more, and as well as stratification of the risk of infection at the point of time. POCAL and CRP will tell us whether may aid in diagnosis of infection. But if a patient is clinically dilated, warm in the peripheries, there is obviously a worry about infection. These are day 3 post-operation. I think starting antibiotics early is not contraindicated, neither is it something that I will frown upon. And then after that, then we gauge response clinically. In fact, we use POCAL and CRP as a guide to de-escalate antibiotics more often than to diagnose, because we know POCAL and CRP is not exactly the most sensitive in diagnosing, because they are only for bacteria, and what Jia-Yin said. It can be confounded by so many things. At the end of the day, clinical judgment is probably still the way to go forward, and a healthy clinical suspicion. If it's day 1 post-trauma and you suspect infection, then we certainly hope that this patient has a good evidence of infection before a trauma, before you initiate antibiotics.
One of the questions from the audience is the choice of antibiotic in a suspicious infection or severe sepsis. What kind of antibiotic would an anesthetist choose?
So I think most a simplified view will be follow what your antibiotic stewardship program in the hospital suggests. In a very, very sick patient, obviously you go, in my opinion, I'll go very hard, I'll go very high dose, and then I'll de-escalate, and then narrow down spectrum if they are very sick. In those not so sick ones, then you go for the most sensible organism that your institution faces as per your antibiotic stewardship program.
Absolutely, and I think that's where the infectious disease people, the microbiologists come into the fore, where they can tell you very well what the prevalent strains of the bacteria and other organisms in their ICUs. So you can moderate the use of the appropriate antibiotic, as was discussed with Dr. Joel. Dr. Jerry, anything else? Well, with this, we come to the end of the open forum, ladies and gentlemen. I must thank on behalf of the Asian Collaboration for Trauma all our esteemed faculty and the reactors, and I must thank my colleagues, moderators, Dr. Jerry and Dr. Benedict, for moderating this whole session. The scientific session comes to an end.